So this patient, the patient in the room is a 67-year-old male, and he has Barrett's esophagus, C0M2 in 2017, low grade. In September 2022, they saw a lesion which was a little bit more concerning, showed high grade focally. So today we're going to do a lesion assessment. So is this the next case? I think so. 80-year-old male with a polyp in the duodenum, also with a short segment Barrett's esophagitis, high-grade dysplasia. Control biopsies were negative. So this is the duodenal polyp, 20 millimeters, and we want to ask this question. What is the increased risk of developing a squamous cell esophageal cancer drinking hot liquids? So you can, during this session, you can all fill out the poll, and we will announce then the winner at the end. Okay, so first speaker now will be will be Professor Bishops, and we might want to see his slides. Thank you.
Thank you very much, Lopke. So if I can get my slides up. Okay, so I will try to introduce the different modalities that we use in endoscopic imaging, focusing on the upper GI tract, obviously. So after this talk, you should be able to understand how these different imaging modalities work. So it's going to be a little bit technical and understand also the advantages and shortcomings of these techniques. So if you put on the NBI here, that can also help you to see these darker streaks in the squamous mucosa, which are totally not visible here. So if you see an isolated event like this without any other signs of inflammation in the rest of the Barrett's, you should consider it to be suspicious, I think.
Yeah, and also it's not linear. It's slightly irregular, and it's slightly shouldered.
Yeah, that's important.
Yeah, it's definitely not reflux.
It's short, David. It's not a long segment of Barrett's. I think people are maybe pay more attention with the long segment. But this is a great example of when it's short, you still have to look at it very thoroughly.
And we were talking about biopsies, so some people might think, Michael, that's a biopsy site, because this guy had a gastroscopy 2 weeks ago, and we were saying that maybe the fact that you've got multiple biopsy sites around here that are all healed, but this one is not healed, is maybe an interesting observation as to why this is not a biopsy helpful, site.
But it doesn't look like a biopsy site.
No. We agree with that as well. So to better image this, what would the panel suggest? Near focus? Okay, we can do near focus. Is anyone using underwater imaging for these things?
I mean, look at that. You don't need to.
Okay, but I would argue that maybe it adds a little something, and let's just try it.
Yeah. I know you wanted to say something.
No, it's very interesting, the vision we have now with the near focus, because the discussion to characterize that as a biopsy scar, when you are just using the near focus now, clearly it makes the difference, because you see all those corkscrew vessels in the middle around the fibrin area, and this is what you see in superficial cancer. So there is no more doubt when you use this near focus in this area.
I mean, Michael, I think like the water, for me, it just makes it all sit up a bit more. But whatever, like what you see there, I mean, can you describe that for people? So if I'm thinking it's a biopsy site, then that's just that bit in the middle, right? And they recently showed that this significantly predicts the rate of cancer in patients. So that scoring system predicts whether patients will get early gastric cancer in the future. So key message for you guys at home: risk of gastric cancer can be determined by endoscopic imaging. And when we do our gastroscopy, if we've got a patient who's got no intestinal metaplasia or focal intestinal metaplasia limited to one area of the stomach, they are at low risk of early gastric cancer. And if we've got a patient with widespread intestinal metaplasia, that's extensive, they are at high risk. So we can use high definition white light, nicely covered already by Raf's talks. I recommend you go back and see those if you haven't, if you're just joining now. And this is what they look like, these Paris classifications. We're going to go through many more examples. You can use dye. Often people don't. It has been an expert series associated with better rates of pickup and better rates of determination of depth of invasion. But let's be honest, in routine practice, most people are not doing it, and therefore it's replaced by virtual chromoendoscopy. This is a lesion. You can see a demarcation line nicely observed also in Raf's live case, in the live case I just did. You can almost argue there's a demarcation line in Michael's, except in Michael's case. So just on to the junction of the antrum and the corpus.
So what you can see there is you can see a beautiful demarcation line. The center of the lesion, you can still see some vasculature, but it's a little bit, and it's reasonably well organized, but to me that looks like at least high grade, if not intramucosal. There is definitely a loss of the mucosal pit pattern.
You see it better there, probably.
And the edge, yeah, and the edge of the lesion looks even more suspicious. So just at about 8, 9 o'clock of center of the image. So that's where I'd probably direct my biopsy.